So when we talk about acute decompensated heart failure as compared to de novo heart failure, we all know that acute decompensated heart failure, they have more risk of mortality, the risk of recurrence of hospitalization is higher, and the risk of arrhythmias and hemodynamic abnormalities and renal dysfunction is far more in acute decompensated heart failure as compared to patients who are otherwise stable and doing good. If you look at the total data that we have, the mortality rate is significantly high in de novo heart failure patients who are hospitalized versus patients who have acute decompensation with a history of chronic heart failure. So naturally, when we are treating patients with acute decompensation or recurrent decompensation, we'll have to be more aggressive and we'll have to be more worried about the renal functions in such clinical scenarios. Now talking about role of ARNI in acute heart failure patients. So if you look at the PARADIGM-HF trial, it did not have a patient, this population's representation, so we did not have any clue. And so to sort out this worry, there was a different trial that was designed, that was PIONEER-HF trial. Now if you look at the study design of PIONEER-HF trial, so the patients were randomized into two groups, one group receiving placebo and other group receiving the ARNIs, and these patients were the patients who were admitted with acute heart failure, who were hemodynamically stabilized, and then they were off inotropes for at least 48 hours. Now if you look at the if you have to talk about the exact enrollment criteria for the PIONEER-HF trial, patients' systolic blood pressure should be more than 100 millimeters of mercury for at least 6 hours before initiating the therapy. There should not be any symptoms of hypotension. Patients should not have any increased requirement of diuretics in past 6 hours before the randomization. Then patient should not be on intravascular vasodilators or inotropes before initiating the therapy for at least 24 hours. If patients had fulfilled all these criteria, they were randomized into two groups. One is the ARNI, other is enalapril, and then they were blinded and followed over a period of 8 weeks. Now during this 8 weeks, the primary endpoint that was monitored was change in NT-proBNP. We all know that NT-proBNP go hand in hand with the survival rates and prognosis in patients with heart failure, and that's why NT-proBNP was followed. The second endpoint or the secondary endpoint that was monitored in this trial was the cardiovascular death or hospitalization for heart failure. It was found that when the patients were treated with ARNI as compared to enalapril, the NT-proBNP levels reduced better in the ARNI group as compared to ACE inhibitor. So that was one very important finding. And second important finding was the risk of recurrent hospitalization or cardiovascular death was significantly less in the ARNI group as compared to the enalapril group. Even if we talk about the adverse effects, there was no significant increase in the adverse effects in the ARNI group as compared to ACE inhibitor. So it was pretty clear that when ARNI was started in acute heart failure patients, after initial stabilization, they tolerated it better and the outcomes were better as compared to the enalapril, which is otherwise a recommended guideline based therapy in such clinical scenario.